let's see, we've got Dr. Lai, we've got, and Dr. Bast may be joining us shortly. So since it's 2 o'clock in the top of the hour, we've got Dr. Stafford, Dr. Lai, Dr. Mavroidis, Dr. Wong, are you on? We have Jihan. Let's wait. Let me text Dr. Wong. He's our
he just logged in.
okay, fantastic. We'll get Jihan going here.
Oh wait, and then he disappeared. He's gonna probably come back again. He's probably having problems. There he is.
Okay.
Hello.
All right, Jihan. We've got
How are you?
we've got a quorum of the committee.
Okay.
So while people are logging on, I'll kind of introduce and lay out the ground rules of this exciting thesis defense by Dr. Mohamed. For those of you who know him well, Dr. Mohamed is a stellar physician scientist, and we're thrilled today to hear his public defense of integration of biomedical imaging and translational approaches for management of head and neck cancer. This PhD dissertation defense is submitted to the University of Texas Graduate School of Biomedical Sciences. And we're thrilled today to be joined by his advisory committee, Dr. Stephen Lai, Dr. Jihan Wong, Dr. Jason Stafford, Dr. Robert Bast, and visiting us from North Carolina, Dr. Panagiotis Mavroidis. The structure of the thesis defense is as follows. Dr. Mohamed will have up to an hour for a public presentation of uninterrupted content from his defense, during which time we will take no comments nor questions. Immediately following, we will have a brief congratulations by his advisory committee before moving into a public question and answer session, which will last between 15 and 30 minutes. So during the thesis defense, if you wish to ask a question, you don't have to give the question, but please let me know by putting in the chat that you would like to ask a question so that we can move through those in a timely fashion. So we'll do the initial hour of Dr. Mohamed's presentation, a brief congratulatory moment, and then move to the public session. After the public session, we'll then recuse to the private examination, which will be attended by the advisory committee members and any GSBS full faculty who wish to observe. So that is the kind of structure of today's exciting event. I would ask everyone to please mute your microphones, and if you don't mind, during the course of the examination, turn off your cameras so that we can give full attention to Dr. Mohamed and his presentation. With that, Abdallah, I'm pleased to hand the virtual podium over to you and for us to hear about your exciting work.
Excellent. Thank you, Dr. Fuller. Good afternoon, everyone. Thank you for joining in, and thank you, Dr. Fuller, for the great introduction. So the title of my dissertation is The Integration of Biomedical Imaging and Translational Approaches for Management of Head and Neck Cancer. This is the agenda of my presentation today. I will start with a brief personal and research background, then an introduction of my thesis, followed by the hypotheses and the specific aims. I will then give a brief overview of each of the projects completed in each specific aim, and finally, the potential future directions and the take-home messages. Introduction of my dissertation. The head and neck tumors encompass a very diverse group of tumors that arise at different locations in the upper aerodigestive tract. And when you add the thyroid tumors to the list, it affects around 110,000 individuals per year in the United States, with around 17,000 deaths from the disease. The prognosis of head and neck cancers is considerably variable according to different clinical parameters, like tumor and nodal size and location, human papillomavirus or HPV status, age and comorbidities of the patients, smoking status, tumor grade, and so on. This gives a wide range of prognosis, ranging from excellent prognosis as in early HPV positive oropharyngeal tumors to very deadly disease in advanced HPV negative tumors in heavy smokers, as well as in anaplastic thyroid carcinoma. Broadly, you can cluster head and neck tumors into low, intermediate, and high-risk groups according to the likelihood of treatment failure. Patients with low risk of disease relapse are likely over-treated with the current standard of care, and we have to find more smart strategies to reduce the radiation-induced toxicity, while patients with high risk are probably under-treated and need treatment intensification or combination with novel agents. On the other hand, patients with intermediate risk need better treatment, adaptation, or personalization strategies to maintain their local regional tumor control while minimizing toxicity. The external beam radiotherapy is a cornerstone of treatment of head and neck tumors, both in the definitive setting, whether single modality or in combination with systemic therapy, and as well as in the adjuvant post-operative setting. The goal of radiation is to improve the therapeutic ratio by maximizing tumor dose while minimizing the toxic dose to adjacent normal tissue. The standard of care for curative intent organ preservation treatment is achieved by prescribing radiation treatment in a daily fractionated manner. And we achieve this by manual segmentation of gross tumor volumes in planning CTs for the patients and designing a clinical target volumes or CTVs to be typically targeted by a dose of around 66 to 70 gray without exceeding the critical doses or dose limits for the organs critical organs at risk like spinal cord and so on. As seen in this graphic, the modern radiation techniques like IMRT or VMAT or IMPT allow for more conformal dose delivery to spare normal tissue as much as possible. However, they lack the ability to individualize and optimize radiation according to the response of target volumes. This is because of the deficiency of reliable predictive biomarkers that indicate the nature of disease response to radiation, either before or during radiation, to allow effective treatment adaptation at actionable time points. In addition, there is steep dose gradients that requires meticulous assessment of the patterns of failure, especially marginal ones, as well as normal tissue toxicities induced by the intermediate and low doses along the beam path. To be able to achieve this, non-invasive imaging such as MRI can provide important information related to tumor characteristics and response to radiation. Anatomical MRIs have superior soft tissue contrast and can help in precise target delineation, while quantitative MRIs can be used as a surrogate of tumor response and normal tissue toxicity, which can help in treatment personalization. Furthermore, the integration of MRI into radiation delivery devices such as MRI linear accelerators enable us to obtain information related to both anatomical changes and functional changes on a more granular fashion, potentially on a daily basis, without the additional resources like a special visit to the MRI scanner every now and then and excess radiation dose or contrast exposure for the patients. This opens the door to many great opportunities and potential for to monitor gross anatomic and biological changes induced by radiation on frequent basis, which can be used to adapt treatment plans at an actionable time points during treatment, which can be as little as like a single time point during treatment, or as many as weekly or even daily replanning. This remains to be investigated. But first, we need to establish the correlation between these imaging changes and tumor response and treatment outcomes. An example of the quantitative MRI sequences available and well studied now is diffusion-weighted imaging, or DWI. DWI relies on the capacity of MRI to assess the Brownian motion or diffusion of water molecules within individual voxels. DWI is calculated with 2B values using a mono-exponential fit to estimate the apparent diffusion coefficient. As you see in this example that a B0 and B800 is used to create the apparent diffusion coefficient map, and you can appreciate the diffusion limitation within the tumor because of the high density of the tumor cells compared to the free diffusion you can see here in the CSF, and the intermediate is the normal tissue with normal diffusion. So DWI is advantageous, and you can see it has its inherent endogenous contrast without requirement of exogenous contrast injection. Also, it doesn't use ionizing radiation. It's quantitative, quick, and can be easily incorporated in radiation platforms. Several previous studies have shown a potential for DWI to predict radiation response and local control. However, most studies were retrospective with mixed tumor subtypes and inconsistent protocols, and sometimes disagreement in some findings. So it was hard to reach definitive conclusion on the best way to integrate it in radiation adaptation or outcome prediction. Our group also reported a pilot data set to investigate the kinetics of DWI in a form of DWI named intravoxel incoherent motion, or IVIM, that separates the diffusion parameters from the perfusion parameters. And in this study, we included 31 patients of oropharyngeal cancer that had their images acquired in the MRI simulation immobilization techniques. And the results of these patients showed that delta changes of ADC, or apparent diffusion coefficient, and delta pure diffusion can predict mid-treatment complete response with a good AUC performance of 0.87. Dynamic contrast enhanced MRI, or DCE MRI, is another non-invasive imaging modality that can be used to measure tissue microvasculature. It is performed by obtaining sequential images before, during, and following the injection of contrast. Dynamic T1 weighted images are used to observe the extravasation of contrast from vascular space to the interstitial space, providing information about blood volume and microvascular permeability. The accumulation of contrast agent in the interstitium results in a signal increase and a subsequent washout. Signal intensity will change in proportion to the contrast agent concentration, and the acquired signal is used to generate intensity curves, as you can see in this curve, which is along with the pre-contrast T1 value and the arterial input function, or the AIF, obtained from the arterial blood plasma concentration as a function of time, can be used to generate parameter maps like K-trans, BE, BP, and KAP. This diagram shows the examples of what these parameters represent. For example, K-trans is the volume of transfer contrast between the plasma and extracellular space per unit volume of tissue. KAP is the opposite, is the rate constant of contrast reflux to the intravascular space, and VE is the volume of extracellular space per unit of tissue. In a previous study by our group, we showed that DCE MRI was able to detect dose-dependent changes in both K-trans and VE maps of patients' mandibular bone. In this study, we showed that according to the dose given, there is a pattern of whether these parameters will increase and recover or stay stable. Few prior studies showed that DCE parameters changes in the salivary glands post-radiation can be also measured. However, DCE MRI parameters correlation with solid toxicity endpoints like xerostomia, osteoradionecrosis, and dysphagia remains to be established. In addition to MR parameters, additional opportunity to predict outcomes exists in radiomic feature analysis. Radiomics is a method that extracts large number of features from radiographic medical imaging using data characterization algorithms. These features have the potential to uncover disease characteristics that fail to be appreciated by naked eye. Features belongs mainly to three categories, which are intensity, shape, and texture features. In a previous work done by our group, also we showed that radiomic signature composed of two intensity features from radiotherapy or the baseline imaging, CT imaging of the patients were correlated with local regional tumor control in oropharyngeal cancer patients, and can be used to cluster the patient into favorable and unfavorable groups. All the approaches described above, including functional MRI, radiomic, and patterns of failure analysis, can potentially allow for better stratification of patients to accurate risk groups, tailoring of radiation therapy doses with the potential of dose escalation or de-escalation, and prediction of tumor response and disease outcomes, as well as the prediction of side effects and normal tissue toxicities. Therefore, the clinical component of this work addresses the unmet need of the proper integration of these imaging modalities to achieve the listed goals. However, certain tumor types still fail treatment despite maximal radiation dose delivery combined with multimodality treatment that may include surgery, chemotherapy, and/or targeted agents or immunotherapy. Anaplastic thyroid carcinoma is a clear example of such tumor with a median survival of less than 12 months despite maximal therapy. In a national cancer database review done by our group and published in Cancer Journal, the anaplastic thyroid cancer patient treated between 1998 and 2012 were analyzed. In this study, we showed that higher radiation doses were associated with improved survival for patients with unresectable anaplastic thyroid tumors. However, the overall survival was poor, with a median survival of around 7 months, and therefore more effective systemic therapies are urgently needed in combination with radiation. Therefore, the translational part of my work is designed to address these aggressive tumors by identifying effective agents to be validated in authenticated in vitro and in vivo tumor models against these aggressive tumors with poor prognosis. So the hypothesis to address the previously stated goals and unmet needs, we designed the current dissertation to have two main research components, clinical and translational. The clinical hypothesis states that the currently available imaging tools can be integrated with radiation therapy platforms for prediction of tumor response, outcomes, monitoring adaptation of radiation dose, as well as characterization of patterns of failure and normal tissue toxicities in head and neck cancer patients with potentially curable tumors. The translational hypothesis of my dissertation states that the imaging genomic translational research can improve disease diagnosis, prognosis, discover novel biomarkers, and identify genomic mechanisms associated with phenotype formation. In addition, the utilization of high-throughput drug screen with subsequent preclinical testing and drug validation in authenticated models will identify effective agents against the aggressive head and neck tumors. To test these hypotheses, we propose the following specific aims. Aim 1 is to determine the feasibility and dosimetric benefits of MRI-guided dose adaptation strategy for HPV-positive oropharyngeal cancer using serial in-treatment MRIs acquired in radiation positioning and immobilization setup. The working hypothesis is that T2-weighted anatomic MRIs can be used for MRI-guided dose adaptation to achieve same tumor control as standard therapy, but with additional screening of surrounding normal tissue. To achieve this aim, 2 projects were done. The first project was standardization of the MRI integration in the radiation applications, and the second one was the MRI-guided dose adaptation. The aim 2 of this work was to determine the quantitative MR parameters associated with tumor response, oncologic outcomes, and normal tissue toxicity in patients treated with definitive radiation. And to achieve this aim, 2 projects were done. The first one was DWI as or diffusion-weighted imaging as a biomarker for tumor response and disease control. And the second one was dynamic contrast enhanced MRI for assessment of normal tissue toxicity. Aim 3 was to develop and apply a methodology to standardize the analysis and reporting of the patterns of failure after radiation or IMRT for head and neck. And to achieve this aim, we implemented or completed completed 3 projects. The first was the methodology development. The second was the application of this methodology for the analysis of post-operative IMRT recurrences. And the third one is to study the patterns of failure-guided biological target volume definition. The fourth and last aim of this work was the translational aim, which was to determine the association between imaging phenotypes and genomic mechanism in head and neck cancer and identifying effective systemic agents against these aggressive tumors. The first project completed under this aim was the association between imaging phenotypes and genomic mechanisms. And the second one with a high throughput approaches to identify effective systemic agents for the treatment of anaplastic thyroid cancer. For the first project in AIM1, which was published in CTRO journal, and it was a prospective assessment of the MR geometric distortion using point-based landmark measurements in MRIs acquired in radiation treatment positioning compared to the standard of care planning CT. We aimed in this work to determine the intra and inter-observer variation that exists when measuring specific distances between landmarks on both the CT and MR images after rigid co-registration. And the second aim was to verify that MRI geometric distortions are within the practical limit to support its inclusion in the clinical utility of MRI-guided radiotherapy. 20 patients were included in this analysis, and we assessed the geometric distortion by comparing 430 landmarks measurements obtained at different levels, including skin, bone, and soft tissue landmarks in horizontal and vertical planes in both MRI planning and CT scans. We identified the identical landmarks in both images, and we measured the distances in the MRIs versus the gold standard CT. And then we measured the differences in these measurements to get the levels of distortion compared to the CT. The median overall distortion for all landmarks in this study was 1.06 millimeters, and there was no statistically significant differences in the magnitude of distortion in vertical versus horizontal landmarks or landmarks at different levels in the image field of view. The only difference was in the magnitude of distortion of peripheral landmarks compared to more central landmarks, which was expected because of the distance from the isocenter. And we find that there is the interclass correlation showed an agreement between different observers with no major disagreement. There were favorable results, and the distortion is considered clinically insignificant. So we concluded from this study that MRI geometric distortions in radiotherapy planning application were acceptable and clinically insignificant errors of less than 2 millimeters compared to that of the CT gold standard. The second project in this specific AIM1 was using these high-quality MRIs. We proposed a novel MRI-guided IMRT dose adaptation strategy for HPV-positive oropharyngeal cancer patients, where dose to the gross disease is reduced on as-needed basis, such as responders could achieve substantive or significant dose reduction to adjacent normal tissues at level not observed in standard radiation treatment, while non-responding disease would be receiving the same dose as the standard of care. The results of this work was also published in CTRO. And in this study, we had in silico design where the baseline and biweekly MRIs were obtained for 5 OPC patients or oropharyngeal cancer patients. For each patient, we created 2 IMRT plan, a standard of care plan, and an adaptive treatment plan. The prescription dose for the standard was 2.12 gray per fraction for 33 fractions for the initial planning target volume or PTV, which included the clinical target volume plus 3 millimeter margin. For the adaptive plan, we created a new adaptive GTV and segmented this on serial MRIs if there is a detectable shrinkage in the initial GTV, and then we created the clinical target volumes, the adaptive clinical target volume for the subsequent weeks. You can see in this example, this is a patient that had a left tonsil tumors and left neck nodes at the baseline, and he had a complete response at the primary site and like partial response in the neck nodes, and thereby the CTV volume were markedly decreased. And you can see in this graphic, 3D graphic, that there is a big difference in the volume of high dose CTV in the initial treatment plan versus in the adaptive plan. So this volume is reduced from high doses and received the elective doses. Overall, the proposed approach was associated with an average reduction in the dose to planning target volume of 12 grays. Adaptive replanning was associated with the reduction of dose to the organs at risk, particularly to swallowing muscles, which translated into a reduction of normal tissue complication probability of toxicity endpoints like dysphagia, grade 2 and more, feeding tube persistent at 6 months, and hypothyroidism at 1 year post-treatment. We concluded that MRI-guided adaptive approach is technically feasible, safe, and advantageous in reducing dose to organs at risk, especially swallowing muscles. The first project in the second aim was the aim of this project was to determine the diffusion-weighted imaging parameters associated with tumor response and oncologic outcomes in a prospective cohort of head and neck cancer patients treated with definitive radiation. In this project, we included 81 patients with oropharyngeal cancer mainly, and patients had MRIs pre, mid, and post-radiation. Treatment response was assessed at mid-treatment and at 8 to 12 weeks post-treatment using the UTHealth criteria, and was defined as complete responders versus non-complete responders. This diagram showed the workflow method that we use to segment the target volumes and to propagate the segmented structures to the co-registered DWIs to extract the baseline ADC values, and then the co-registration of mid-treatment images to the baseline images to get the delta changes in the same size and shape of the original location of the tumor, and analyze these delta changes with response and treatment outcomes endpoints. The median follow-up in this study was 31 months. The pre-treatment ADC was not correlated with tumor response or oncologic outcomes. For patients with post-radiation complete response, there was a significant increase in the mean ADC at mid-radiotherapy compared to baseline, while patients with non-CR or non-complete response had no statistically significant increase. The recursive partitioning analysis, we did identify that delta ADC mean at the primary tumor site of less than 7% changes at mid-radiation treatment as the most significant parameters associated with worse local control and recurrence-free survival. And as you can see from this Kaplan-Meier curves, that patients who had more than 7% had performed much better in terms of local control and recurrence-free survival than patients who had delta ADC mean less than 7%. We also did univariable and multivariable analysis of the prognostic outcomes, which showed that the delta ADC more than 7% was significantly associated with better local control and recurrence-free survival. And the addition of this parameter, delta ADC mean, significantly improved the C indices of local control and recurrence-free survival models compared with the standard clinical variables, as you can see in these figures. We concluded that the prospective imaging study of head and neck cancer patient, in this prospective imaging study of head and neck cancer patient, that delta ADC parameters at mid-radiotherapy represent a strong predictor of local recurrence and recurrence-free survival. And patients with no significant increase at mid-therapy of ADC at the primary sites relative to the baseline values are at high risk of relapse. The second project completed under this specific aim 2 was to assess the DCE, or the dynamic contrast enhanced MRI vascular parameter correlation with the osteoradionecrosis of the mandible, which is the most debilitating complication of head and neck radiation treatment. The result of this work was also published in the journal, and in this study, we included 30 patients with advanced grade ORN requiring surgery. The median time to ORN, or osteoradionecrosis development, was 38 months. In this study, we collected the MRI as well as the CT scans to segment the 3D volume of the ORN, and we call it the ORN volume of interest. And then we created a contralateral controlled volume of the same size and shape to compare between the vascular parameters of the ORN area compared to the healthy mandible. Our results confirmed that there is a quantitatively significant higher degree of leakiness in the mandibular vasculature as measured using the DCE parameters of the area of ORN versus healthy mandible. As manifested in these figures, you can see in the box plot, there was a very significant increase in the K-trans and DE parameters. On average, it was 3-fold increase for K-trans and 2.7-fold increase in DE for this volume of interest. And you can see here the histogram of the volume of interest for ORN are very different from these of the control. And in this figure, you can see that the leakiness was mainly higher in these areas compared to the normal mandibular one. So in this study, we concluded that higher degree of vascular leakiness in the mandibular areas of ORN as measured using the DCE MRI parameters compared to that of healthy mandible. So for specific aim 3, the first project was to develop a workflow methodology to standardize the analysis of head and neck cancer patterns of failure after IMRT. We used both geometric and dosimetric parameters, and we assessed in this study the impact of registration technique on the patterns of failure, quantitative analytic parameters, and we developed a granular classification and nomenclature to optimize the accurate reporting and of distinct failure typology. In this study, we had included 25 patients with evidence of local and or regional recurrences following intensely modulated radiation treatment. We retrieved patient planning CTs and doses, as well as the first image depicting recurrence. The recurrence was manually segmented, and then the recurrence image was co-registered to the planning CT using both rigid and deformable image registration methods. And finally, the recurrence target volumes were propagated to the planning CT, and its centroid was created to be compared relative to the original planning target volumes and dose. As seen in the graphical table, these failures were then classified into 5 types based on combination of spatial and dosimetric criteria. So we have central high dose, peripheral high dose, central elective dose, and peripheral elective dose failures, and extraneous failures. And for each type, there is a potential causes of failure and potential technical interventions. A total of 26 recurrences were identified in this study, and using the formable image registration, recurrences were assigned to more central target volumes compared to rigid, as detected by the spatial centroid map. And we showed that the rigid registration for IMRT plans resulted in incorrect localization relative to the prior target volumes, and those in 16% of failures. The secondary quantitative review by expert radiation oncologists of all clinical and imaging data of these recurrences that were classified as peripheral using the rigid image registration agreed with the deformable assignment as more central location. As you can see in this example, that just changing the image co-registration technique changed how you define the failure. That's why a meticulous validation and meticulous quality assurance of the deformable image registration technique used in these studies is mandatory to be able to obtain more accurate results. So we concluded from this work that rigid image registration method tends to assign failures more preferably compared to deformable methods. And using deformable methods, failures originated in high-dose target volumes in this study that included mainly definitive patients and received full prescribed doses, suggesting biological rather than technology-related causes of failure. And we also recommend that a validated deformable image registration method is highly recommended in addition to a granular combined geometric and dosimetric based failure characterization as a standard of care for large-scale patterns of failure reporting. So in the second project in this aim, we applied this patterns of failure analysis methods in the identification of patterns of failure after post-operative IMRT, this time to oral cavity cases. The results of this paper was also published in Radiation Oncology Journal. And in this study, we applied the same patterns of failure analysis methodology to get the location as well as the doses of the origin of failures. And our results in this study demonstrate that nearly half of the patients with local and regional failure included in this study had non-central high-dose recurrence compared to the more central dose recurrences in definitive setting. And these recurrences in operated tissues are less prone to present concentrically as do recurrences that occur following the definitive radiation. The likelihood of recurrence manifesting in the epicenter of disease after surgery is unlikely, particularly when large volumes of tissues are removed and replaced by free flaps, creating significant variation in the irradiated anatomy compared to the pre-surgical anatomy. Approximately half of the patients in this study, as I just mentioned, was non-central high-dose failures, and we concluded that contrary to the non-oral cavity size or the definitive IMRT, a substantial proportion of failures are non-central and requires a meticulous multi-physician quality assurance, and as well as necessitates that we have to further investigate the potential practice changes in the definition of targets in these patients. The last project under this aim was to identify the geometric origin of recurrences relative to the pretreatment FDG PET scans and the relative to the original target volumes as well. So in this study, we wanted to identify the standard uptake value threshold that overlap with the majority of recurrences. So we also wanted to determine the most feasible PET boost volume with the most overlap with the recurrence origin to be able to get the smallest boost target volume size relative to high dose clinical target volumes. For this analysis, we retrieved the pre-radiation PET scans of the patient as well as the planning CT and recurrences. And we did co-registration, and after the co-registration, the different percentage or threshold of the maximum SUV volumes were identified on the pre-radiotherapy PET scans, and isotropic margins of iterations increments of 2 millimeters were added around each iso intensity volume to create a boost tumor volume. For each deformed biological target volume, the overlap with the centroid of all high-dose type A recurrences was recorded, and the boost tumor volume was considered adequate to capture the centroid of recurrence if the overlap was greater than 95%. With no added margin, we showed that the examined SUV threshold didn't overlap with the majority of centroids of recurrences. For example, when there is no margin expansion around the SUV 50, only 20% of the type A primary site recurrence centroids were overlapped or covered. And however, with additional margin expansion, you can see that more than one boost target volume alternative resulted in a coverage of 90% of the primary centroids or primary centroids of the recurrences. So the BTV 50 that or the SUV 50% of the maximum that is suggested in as few clinical trials of dose escalation would probably undercover the origin of recurrences for the majority of these patients, and that a BTV or boost target volume of 50 plus 10 millimeter is likely to be more reliable to be used because it covers 90% of the recurrences origin, as well as it has low average relative volume to CTV, so it's acceptable size to be boosted, and it has least percent average percent boxes outside the CTV or high dose CTVs. As you can see in this heat map, that the just the SUV 50% of the max only covers a few percent of recurrence origin, and most of the recurrence origins would be covered by SUV 50% plus an additional 10 millimeter margin. So from this study, we concluded that when we correlated that with the pre-treatment PET, most post-radiation recurrences originated in an area that would be covered by a 10 millimeter margin on the volume of 50% of maximum FDG uptake. Our data also serve to define a candidate boost target volume that appropriately covers the subvolume of highest radio resistance based on objective patterns of failure mapping using rigorous imaging processing to afford increased spatial certainty as a prior for further investigation and extra institutional validation. For the translational aims, the first project in this aim was published in the GCO Clinical Cancer Informatics, and the aims were to assess the relationship between tumor imaging phenotypes and underlying genomic mechanisms using whole genome measurements from the Cancer Genome Atlas with radiomic data from the CTs of matched patients from the Cancer Imaging Archives. We also aim to determine the potential of using CT imaging as a non-invasive biomarker, predicting the tumor molecular status for head and neck tumors. In this study, we included 126 patients. We collected the multi-layer whole genome data and tumor radiomic features after matched baseline CTs were retrieved and segmented for radiomic features extraction. First, we did a linear regression analysis to identify statistically significant associations between radiomic features and gene-level genomic features. Second, for the whole genome measurements, including gene expressions, copy number variation, and promoter region DNA methylation, we investigated their associations with tumor radiomic features at the pathway level, using regression and gene set enrichment analysis. Finally, random forced classification was used to predict patient HPV status and p53 mutation status based on the radiomic phenotypes. Our results, as you can see in this heat map, showed a high degree of statistically significant association between radiomic features. Radiomic features are classified into 5 main categories in these colors. Gray level co-occurrence matrix, gray level run length matrix, neighbor intensity differences, intensity features, and size and shape. And here are the different transcriptional activities. And you can see we only included the significant differences. Red indicates the positive associations, and green indicates the negative associations. And as you can see from this heat map, that there were a lot of significant association between transcriptional activities of cancer-related genetic pathways with radiomic features, and consistently we found that the transcriptional activity of apoptotic pathways is negatively associated with tumor size and shape irregularity features. We also found that the pathways related to immune regulation were also negatively associated with tumor size features. And this is, to be honest, is expected because larger tumor with irregular shapes tend to evade the apoptotic mechanism or regulatory immune mechanism. So we also found that the pathways related to we also found that we can have 5 radiomic features to create a model that predicts for HPV and for disruptive TP53 mutation with decent AUC value as shown in this table, with only 5 features from the CT images. And we concluded from this study that radiomic features are associated with genomic characteristics at multiple molecular layers in head and neck cancer, and provides a justification for continued development of radiomics as a biomarker of relevant genomic alterations. Last but not least, the final project in this aim was to identify effective systemic agents against aggressive variants of thyroid cancer using high-throughput drug screen as an initial filter for subsequent preclinical testing and drug validation in authenticated cell lines and in vivo models. In this study, we included 12 human thyroid cancer cell lines. 7 were anaplastic thyroid cancer, 1 was poorly differentiated thyroid cancer, and 4 were papillary thyroid cancer cell lines. All cell lines underwent comprehensive genomic characterization prior to drug testing, and high-throughput screens were performed using the NCI's approved set of 102 drugs or agents, and we also add 145 collection of FDA-approved drugs. The effect of drugs on cell growth and survival was measured after 72 hours of drug exposure. We used 3 drug concentrations in a 384 well-plate format. And to identify the most effective drugs, we selected individual agents with maximal normalized growth inhibition at the top 25th percentile relative to other drugs and controls. We also created concentration response curves that were fitted using nonlinear regression analysis, and we created the area under the curve to be used in the development of pharmacological trees for each cell line that shows the level of ESC performance versus all of the different mechanisms of agents used. And for the most effective agents, we did confirmatory testing using 8-point dose response curves. We selected 17 agents for further efficacy testing in all 12 cell lines. The selection criteria included the level of agent activity in the tested cell lines, as well as the persistent activity at lower concentrations. 3 agents were then included in the final analysis, consisting of a microtubule inhibitor, docetaxel, and antifolate pralatrexate, and histone deacetylase or HDAC inhibitor, LPH589, were chosen to be further analyzed based on the screening data and their existing FDA approval for non-thyroid cancer uses. The validation analysis included in vitro and in vivo method. For the in vitro, we did MTT-AC to determine the IC50, and we did colonogenic AC to determine the effectiveness of these drugs. This was followed by in vivo validation in orthotopic as well as patient-derived or PDX models. In vitro validation, we used 2 thyroid cancer cell lines, the HTH83 and K2. We used it to determine the IC50 measurement as shown in this table. The colonogenic AC were also done for further in vitro validation, and the 3 agents were able to decrease the number of colonies formed in both cell lines in a dose-dependent manner at a nanomolar concentrations, with the exception of pralatrexate in the K2 cells. For the in vivo validation, the 3 drugs anti-tumor activity was tested in orthotopic HT83 and K2 tumors. Here are the Xenogen in vivo fluorescence imaging used for the orthotopic tumor measurements at baseline and after each of the treatments. As seen in the box as seen in this box plot. The LBH 589 significantly inhibited tumor growth in both models. Docetaxel inhibited the HT83 tumor growth, while the pralatrexate was able to inhibit K2 tumor growth. To further reinforce these findings, we tested the three agents in two ATC patient-derived xenograft models or PDX models. The first one was ATC1, which was BRAF and P53 mutant. And the second one was ATC5, which was BRAF and TP53 wild type. We find also a significant tumor growth inhibition using the LBH in both of the PDX models. Also, pralatrexate also did a significant inhibition in these two models, while docetaxel only led to significant inhibition of tumor in the ATC1. Agent toxicity were also evaluated as a function of changes in animal weight. The LBH significantly reduced mice weight in all four models by up to 12% after the first cycle of treatment when given at the initial dose of 20 milligram per kilogram, while the pralatrexate significantly decreased the mice weight in the ATC5 model. To ensure that mice survival is completed, we completed the treatment using the LBH at a slightly lower dose, half the dose, 10 milligram per kilogram for the next cycles. We also did immunohistochemical analysis of cleaved caspase-3 as an apoptotic indicator and Ki67 and mitotic count as a proliferation indicator. And as seen in the figure, there was an increase in apoptosis and decrease in proliferation after the treatment, matching with the tumor volume results. We concluded that following high throughput screen with 257 agents, that we identified 3 candidate agents and performed extensive in vitro and in vivo analysis. The HDAC inhibitor was the most effective agent for cell growth inhibition in vitro cell lines, as well as tumor growth inhibition in vivo for all orthotopic and PDX models, making this agent a strong candidate for clinical trial implementation. The inhibitory effect of docetaxel in vivo was specific for P53 mutated tumor alone, while pralatrexate was effective in both anaplastic and papillary thyroid regarding of the BRAF and P53 mutation status. The future application for each aim is briefly, for aim 1, we were able to implement the anatomical T2 weighted imaging guided adaptation of treatment in a clinical trial. The clinical trial is already has been completed for the first phase of this clinical trial, which is to establish the safety and feasibility of this method on a prospective cohort of 15 patients. We had now started the second phase, which is randomization to the MRI-guided adaptive treatment versus standard IMRT, and the study is currently going on. For AIM2, one of the future directions that we need to implement is the external validation of our delta ADC DWI parameter, as well as the K-trans and PE finding for the osteoid necrosis. We also need to use this imaging to interrogate other normal tissue toxicities like xerostomia and dysphagia. And we will integrate a multi-modality and multi-parametric imaging in models to develop more comprehensive prediction of outcomes. Another avenue for future application is a prophylactic clinical trial to treat high-risk patients based on the K-trans and PE changes in patients with high risk to develop osteoid necrosis, and to have these patients in a prophylactic drug trial after the completion of radiation based on their risk profile obtained from the images. For the third aim, we have future direction of secondary analysis of the patterns of failure in clinical trials, both in the national and the international level. And we are also currently doing a consortium of multi-institutions to implement this methodology over a large big databases And also, we try to identify the origin of tumor recurrences relative to the baseline functional MRI parameters like DWI and DCA. For the last aim, we are trying to validate the radiogenomic signature we obtain in our analysis in more larger data sets of mesh imaging, as well as genomic full genome libraries, as well as we are trying for the last project to include the discovered agents in clinical trials like LBH in a phase 1 clinical trial. So the conclusion from my dissertation is, first, we were able to integrate anatomic MRI images in those adaptation radiotherapy strategies, which led to reduction of normal tissue complication probability and subsequent integration into our current active clinical trials. We successfully demonstrated the utility of quantitative MR parameters as a biomarker of tumor response, disease outcomes, and normal tissue toxicity. We developed a novel methodology for analysis, reporting, and interpretation of the patterns of failure after radiation treatment. We also were able to identify associations between genomic features and imaging radiomic features representing different head and neck tumor phenotypes. We identified a validated classes of systemic agents with preferential effectiveness against aggressive thyroid tumors. So I'd like to end my presentation by thanking my advisor, Dr. Fuller, for all his continuous and unlimited support during and well before I joined the program. He provided me with all the guidance, friendship, both in research and life in general. I really owe him all the success I had throughout my research journey, and honestly, I wouldn't be the researcher or person I am today without him. I also like to thank the Fuller Lab, the past, the present, and also the future, for their excellent help and support throughout my research journey. They were exemplar of a true team science, and they are always in my heart. Also, I would like to thank Dr. Lai for all the help and support he provided me before and during the PhD work. He offered me all the resources I needed to fulfill the translational component of this work. I owe him and his lab members, Ying, Yun, Nikhil, all the basic and translational science skills I have. I'd like also to thank my committee members, Dr. Wong, Dr. Stafford, Dr. Bast, Dr. Mafroidis, for all the help and support they offered to me during my research work. And I also would like to thank Dr. Barelli and the entire cancer biology program for all the help and support throughout the PhD journey. And by that, I hope the curtains open to a new and exciting chapter in my career. Thank you all, and I will be happy to answer any of your questions.
Thank you, Dr. Mohamed. As always, phenomenal work and an exciting presentation. I'd like to give a minute or two for a brief congratulation from each of the members of your committee. So we would like to offer our congratulations. So any of the committee members would like to offer congratulations or a brief comment, and we'll do that before opening the public session.
Abdallah, I'd just like to congratulate you on probably a phenomenal talk on how well you took all this research and digested it and put it together and managed to fit it in on time. Very, very well done.
Thank you so much. My pleasure.
Yes, I concur. And particularly in this pandemic, you're able to finish this strong. Congratulations.
Thank you, Dr. Bast.
Yeah, I would like also to add that that's a very thorough and comprehensive work. Very rarely you have the chance of seeing such a work being displayed. I would like to congratulate you for this journey. It's very impressive. Thank you so much for being asked for sharing this with us.
Thank you so much. This is really kind of you.
Hey, Abdullah, it's Stephen. I just want to say that this is really an impressive performance and presentation today. The work is really impressive, not only in its breadth, but also depth, and especially notable for its clinical relevance. So I just want to sort of add my congratulations for this auspicious day. The work today highlights your growth and all of your accomplishments, and I definitely look forward to our continued work together. So thank you.
Absolutely. Thank you, Dr. Lai.
With that, we'll move to the public segment of the defense or of the thesis presentation. So, if there was a brief wish for congratulations from Dr. Kanawate, who had to leave early, but now we open it up to anyone who is in attendance. So, if there are any questions, if anyone wants to ask a question. You may, at this time, raise your hand using the little indicator on Zoom, and then we'll allow you to ask a question for Dr. Mohamed. So we'll open that up publicly, or you can alert me through the chat.
I think it was really clear.
It was exceptionally clear. So there's a hand raised. Dr. Salzio, do you mind? Go ahead. You can turn on your camera and ask Dr. Mohamed your query.
Hey, Dr. Mohamed, congratulations. That was awesome presentation. I was wondering more on the MR-Linac side and using MR for treatment planning. How do you think we can go about improving electron density calculations so that we can truly use MR imaging for precise treatment planning and dose calculations?
To be honest, my way to go for this one is academic and industrial partnership. So they usually, the industry is, when they release a commercial device, they are heavily invested in marketing this, correct? So they want like the majority of institutions to get this device and so on. But the level of enthusiasm in further research how to improve this current like modality to use it in more breakthrough ways requires further efforts. And to be able to do these efforts, we have to, like we did for the academic industrial partnership for the DWI integration, that we are part of it, and Bridget obviously was leading this effort. So I think academic industrial partnership, working with these guys to develop protocols and develop and get funding for this will be the best way to get like commitment to achieve these things.
Excellent. Thank you, and congratulations again.
You're welcome, sir.
Dr. Salzio, other questions in the public session for Dr. Mohamed? And his committee members are reserving questions for later, so don't worry, he'll get a few questions in the examination component. Great. With no other questions, I'd like to congratulate you on behalf of your committee for successful public presentation. Thank the members of the there's a clap. Yeah. Thank the members of the committee. Thank the attendees. As you can see, Dr. Mohamed has an incredibly rich group of scientific and personal collaborators, friends and family who have been kind enough to attend. And we thank you because this is a special moment in a scientist's life when they can, in an unrestricted forum, present a large body of work. There are few times in our careers where we get the opportunity to present a comprehensive and complete narrative of many years of labor. And as you can see from Dr. Mohamed's presentation and the body of folks who are here, the impact and the large capacity for not only improving the quality of science, but also improving our collaborative capacity scientifically here at MD Anderson. So we thank everyone for attendance. We'll give everyone about 5 minutes to wish your congratulations in the chat or verbally to Dr. Mohamed before we ask everyone but the advisory committee and GSBS full faculty who wish to remain for the examination section. So we'll give until 3:15. Thanks, everyone.